My name is Candy Welch, and I'm pleased to be hosting and moderating this webinar for Brain Support Network, a nonprofit focused on education for atypical Parkinsonism disorders and brain donation for all neurological diseases. I'm currently on the BSN board and serve as a leader of our local MSA support group in the San Francisco Bay Area. I cared for my husband, Bob, who passed away in 2008. His MSA diagnosis was confirmed following his brain donation. Stanford is very pleased to offer our 5th webinar in our occasional series on Parkinson's and atypical Parkinsonism disorders. We are recording today's event and uploading it to YouTube, so we will hope that you will pass the information along to others who may be interested. Watch your email after the event for the link. Brain Support Network will be posting a summary on our website, and also we will be posting the actual webinar itself for future viewing. Today's webinar focuses on evaluating and treating urinary problems in Parkinson's and atypical Parkinsonism disorders. After our speaker concludes, we'll hold a question and answer session. Throughout the presentation, we hope that you will submit your questions using the Q&A button that you will see at the top of your screen. In addition, we have received many great questions in advance of today's webinar. We will attempt to address as many of these questions as possible in the time we have allowed. We also ask that you complete our survey. We look forward to receiving your feedback. The link for the survey will be on our slides and in the Q&A box that you'll see at the top of the screen. We thank you so much in advance for helping us to improve. Our guest speaker today is Dr. Ekene Inemchukwu. Dr. Inemchukwu is Assistant Professor of Urology at Stanford University Medical Center. Some of her interests include neurogenic problems in her patients and quality of life issues. I'm now so very pleased to turn things over to our guest speaker, Dr. Inemchukwu.
Thanks for that introduction, Candy. Hello, so today my name is Ekene Inemchukwu. I am a urologist here at Stanford, and today I'll be speaking about Parkinson's disease, multiple system atrophy, other atypical Parkinsonism disorders, and the bladder. And moving forward, I will refer to Parkinson's disease and MSA for the other atypical Parkinsonism disorders such as Lewy body dementia, progressive supranuclear palsy, corticobasal degeneration, given that the bladder symptoms are pretty similar. So in these conditions, in these Parkinsonism disorders, urinary symptoms are very common. We most commonly see overactive bladder symptoms. So what are overactive bladder symptoms? They are urinary urgency, which is a sudden urge to go to the bathroom that you can't ignore. That occurs in about 55% of patients. Urge incontinence, which some people will leak on their way to the bathroom, and sometimes it's a few drops and sometimes it's a big flood, and this happens in about 30%. Urinary frequency, which is going to the bathroom frequently, so that's 8 or more times in a 24-hour period, and that occurs about 35% of the time. Nocturia, which is getting up 1 or more times at night to urinate, occurs in about 90% of patients. And it's often associated with sleep disorders like restless leg, insomnia, and REM cycle disorders. Difficulty emptying the bladder, which we often will present with weak stream and urinary hesitancy. It's often associated with a slow sphincter muscle, though, so that's the muscle that helps keep us continent. It's very slow to open when you try to initiate urination, and that occurs in up to 42% of patients. An enlarged prostate or a prolapsed bladder in a woman can also make bladder emptying even more difficult. Urinary retention, which is an inability to urinate or to empty the bladder adequately, requiring some type of catheterization, and I'll talk a little bit more about that later. That often occurs due to a weak bladder muscle or a non-functional bladder muscle, and it's more common in MSA. So symptoms can range from mild to severe, and they can progress. They can wax and they can wane. They can have significant impact on quality of life. They are present in about 65% of patients with Parkinson-related disorders. Women are generally more affected than men. And the onset of urinary symptoms are a little different when we're talking about Parkinson's and atypical Parkinson's. So in Parkinson's, urinary symptoms typically present after the motor symptoms have come on or developed. In MSA or atypical Parkinson's, urinary symptoms are often the first symptom or the first sign. So they often start before the onset of motor symptoms. And we see that there's a lot of overlap in Parkinson's and atypical Parkinson's. In both, we see urinary frequency, urgency, urge-related incontinence, as we just talked about, weak stream, straining to void, feelings of incomplete emptying. In atypical Parkinson's, we see more of the constant urinary incontinence. Because in Parkinson's, we see more urinary hesitancy, or it takes a while to initiate the stream. So the brain, nerves, and bladder have to work together in order to store and empty urine. So with normal bladder function, when it's an appropriate time to pee, the bladder's full, it sends a signal to our nervous system to let us know that it's full. Then the brain, we check with the brain to see whether it's an appropriate time to urinate. And if it is, then the brain will go ahead and turn everything on, and the bladder will contract, the sphincter muscle will relax, and the bladder will empty. In Parkinson's and atypical Parkinson's, the brain signal to the bladder is not functioning, doesn't function correctly. And so the bladder may or may not be full. It sends its signal to the nervous system, and the brain isn't really involved. So what happens is the sphincter muscle relaxes very slowly, the bladder empties very slowly and incompletely. In MSA or atypical Parkinson's, we'll often see a sphincter muscle that doesn't function well at all. And so it does not close completely during bladder emptying, causing incontinence and leaking. It doesn't relax completely during urination, causing incomplete bladder emptying. And it does not relax at the appropriate time, so it relaxes whenever it wants, and that results in incontinence as well. And it also causes a weak stream and incomplete bladder emptying. So as a urologist, our management goals for our patients are to try to improve urinary continence, improve bladder emptying, prevent urinary tract infections, protect the kidneys from damage and swelling, and improve overall quality of life. So how do we do that? We start with an evaluation. And so when you go in to see your urologist, they're going to take a history. They're going to ask you what symptoms you're having, how long you've been having them, and when they happen. And then they'll also do an examination to just make sure that there isn't anything on exam that may be contributing to your symptoms. Next, they'll move on to doing labs and different tests. So we'll check the urine, make sure we don't see any signs of infection. We'll do a bladder scan to make sure that the bladder is emptying appropriately. We do a urine flow test called a uroflow. This flow machine here on the side, and that will tell us whether the stream is normal or not. Bladder diaries and questionnaires will help us to determine whether the fluid intake and the output is appropriate and whether the urine production at night is appropriate or there's overproduction. Kidney ultrasounds will often get as well, not always, but if we're concerned that urine is being retained and that there may be some urine going back up towards the kidneys, we may check the ultrasound and just make sure that the kidneys are healthy. Finally, we do a bladder function test called urodynamics, which helps us to determine why you're having the symptoms that you're having so that we can pinpoint that issue and try to improve it. So what is urodynamics? Urodynamics, or video urodynamics, is a bladder function test that's kind of similar to getting an EKG for your bladder. So what we do is we place a little tiny catheter into the bladder, which allows us to fill your bladder up with water or contrast so that we can try to reproduce your symptoms and see what's causing it. That tiny catheter also has a little probe on it that allows us to measure the pressure inside of the bladder, and often to measure the pressure inside of the urethra so that we can see whether those two areas are working properly and working together. So urodynamic evaluation measures bladder pressure. It measures your ability to store urine. It measures or evaluates sphincter function, and it evaluates bladder function and emptying. So this is an example of a patient that has Parkinson's with involuntary bladder contractions, or like little bladder spasms, or a spastic bladder. So with all of those contractions there, this patient had some incontinence. And then on this side, we have a patient that doesn't have any neurologic disease and doesn't have Parkinson's disease. And you see a voluntary contraction there, and it's just one contraction and the bladder empties on that. And so the video portion of this is where we sometimes will take x-rays. Not always necessary, but if we have any concern, then we'll take x-rays. So we fill your bladder with contrast, and we're able to take an x-ray and see the shape of the bladder and make sure it's nice and round and smooth and that the urethra is nice and open. So here's an example of a normal bladder and an abnormal bladder. So after your test, your urologist will review the results and make some recommendations. First, we generally will try to determine which broad category you fall under so that we can talk about what your treatment options are. And generally, the three main categories, and there can be other patterns, are underactive bladder or a weak bladder. So this is a weak bladder muscle that doesn't push the urine out appropriately. So you end up with urinary retention, or retaining urine in the bladder. There's also an overactive bladder, a spastic bladder, like the one I showed you earlier, but also poor emptying in that same setting. So in those patients, often they have these involuntary bladder contractions. They have a slow urethra or sphincter that doesn't relax well, and then also a weak bladder on top of that. So often you'll have incontinence of urine and also poor emptying. The third one is detrusor overactivity, which is again involuntary bladder contractions that lead to urinary incontinence. So to kind of differentiate some of the findings that we see in Parkinson's and atypical Parkinson's, on a bladder function test, we'll often see some overlap here. Again, we'll see involuntary bladder contractions in both groups, but with MSA and atypicals, we more likely may see involuntary sphincter relaxation or incomplete sphincter relaxation, and often a weak bladder contraction. In Parkinson's, we may see more of a slow sphincter muscle or delayed sphincter muscle causing a lot of the symptoms. So how do we manage Parkinson's and other atypical bladder symptoms? Well, we kind of think about what the symptoms are, or what the findings are on testing, or use your symptoms to kind of determine what it most likely is. And in someone that has involuntary bladder contractions with urinary incontinence, we'll often start with conservative therapies. So conservative therapies include things like timed voiding. So time voiding is going to bathroom on a timed schedule to try to prevent incontinence. So you're pretty much trying to empty your bladder before you have that involuntary contraction. There's also fluid and dietary changes, which I'll talk a little bit more about in a minute. There's double voiding, which is where you go to the bathroom and give yourself an extra few minutes in there to try to get the bladder as empty as possible. Often you'll go once and you'll be able to potentially go another time and try to get that bladder more empty. There's handheld urinals and bedside commodes, which are helpful for patients that have poor mobility or for nighttime voids to prevent falls. There's condom catheters or external catheters, which are helpful for patients who have incontinence, but they do not have urinary retention. So you must empty your bladder adequately. There's pads and diapers, and then there's avoidance of constipation. The benefits of conservative therapies is that there aren't really any side effects associated with most of these. So fluid management, you want to avoid dehydration, but you want to also avoid overhydration. So you want to get it just right. What is that? It really differs for most folks. 4 to 6 8-ounce glasses of water is probably enough for most people who aren't out and sweating and losing a lot of fluids. But for Parkinson's and atypical Parkinson's, often there's some blood pressure issues and your neurologist wants you to drink more fluid to keep your blood pressure up. So it's most important to follow your neurologist's recommendations on daily fluid intake so that you don't fall and injure yourself. You also want to avoid bladder irritants. So that's caffeine. Caffeine's a double-edged sword. It irritates the lining of the bladder, and it also acts as a diuretic. So it pulls the fluids that you just drank and it dumps it into your bladder. So caffeine, tea, coffee, spicy food is a bladder irritant, citrus, carbonated fluids, alcohol, tobacco, all of those things are going to irritate your bladder and contribute. They're not the cause of your bladder symptoms, but they're going to potentially make them worse. Parkinson's disease and atypical Parkinson's can affect the bowels too. They can slow down the bowels and cause constipation. So how does constipation then affect the bladder? Well, hard stool in the rectum can push on the bladder, push on the urethra or obstruct the urethra and make it more difficult to urinate, make it more difficult to empty your bladder, cause more spasm of your bladder and loss of control, and even cause painful urination, burning, and can contribute to urinary tract infections by causing you to empty your bladder ineffectively or inefficiently. So the goal is to have a soft bowel movement every day to every other day. And so that is something that you can discuss with your doctor to talk about things like fiber and stool softeners and laxatives as needed, and if needed, a gastroenterologist that specializes in neurologic conditions can be helpful. I mentioned bedside commodes before. They're good for people with poor or slow mobility, and they're good for overnight urinary frequency, again, to help minimize falls. Pads, diapers, and bed pads are good options for patients who do not wish to undergo procedures or have failed more conservative therapies. There are many discrete options that are available now, and your insurance may actually pay for all or some of these products. There are external catheters. There are male external catheters like condom catheters, and there are female external catheters now that are options for people who are able to empty their bladders appropriately. So these are for people that have terrible incontinence, but they empty their bladders well. So it's not for use for people who have urinary retention. When conservative therapies are ineffective, then we generally look to medications. Now, there are two broad categories of medications for overactive bladder, spastic bladder with incontinence. And the main difference between these two medicines is that they work on two different receptors, so the side effect profiles are different. The first one is anticholinergics, and the ones you've probably heard about are oxybutynin or ditropan or Detrol or tolterodine. These are common medicines that are used to help calm the bladder so that you can make it to the bathroom and you can go a little bit longer in between urinations. The potential side effects are dry mouth, dry eyes, constipation, and then also it can cause some confusion, especially in elderly patients. So you really have to be cautious when you're using these medications. And when I'm prescribing for my patients, I'm very cautious when I'm prescribing for my Parkinson's patients and atypical Parkinson's. Beta-3 agonists or myrbetriq is another option, and again helps to relax the bladder, but it works on a different receptor, so it doesn't cause the dry mouth and constipation and potential confusion, but it can cause a mild elevation in the blood pressure. And so if you have any elevated blood pressure issues, you definitely need to monitor that, and your doctor needs to monitor that. Thankfully, not usually an issue in Parkinson's or atypical Parkinson's. When behavioral therapies and medications are ineffective, then we move on to what we consider advanced therapies. These include sacral neuromodulation or InterStim. InterStim is like a pacemaker for the bladder. The indications are urgency incontinence, fecal incontinence, non-obstructive urinary retention, and it is actually off-label for neurogenic bladder. So that's for patients with Parkinson's, MS, atypical Parkinson's, it's off-label. It does involve 2 short procedures, outpatient, and it's a safe and reversible procedure with low complication rate. And the success rates in small studies have been shown to be similar in Parkinson's and patients and non-Parkinson's patients. Percutaneous tibial nerve stimulation. This is FDA approved for urinary urgency, frequency, and urgent continence as well. Again, it's off-label for neurogenic bladder. It's done in the outpatient setting with a tiny 34-gauge acupuncture-like needle that goes into a nerve in the ankle. That ankle goes up to the bladder and helps to calm the bladder so you don't have as much frequency or urgency. And that stimulation of that nerve is done for 30 minutes per session, and it requires 12 weekly treatments. It's safe, and the success rates are a little over 50% in non-Parkinson's patients. It's not well studied in Parkinson's patients, though. And finally, Botox, which is FDA approved for neurogenic bladder. So this is the one that is not off-label. This one is FDA approved. Does have high success rates, high patient satisfaction rates, and lasts about 6 to 12 months. It does have potential side effects, which include UTI and incomplete bladder emptying. So if you have more of an underactive or weak bladder or poor bladder emptying in the setting of overactive bladder, then generally you're presenting with urinary retention. And there are multiple causes for this. Again, weak bladder or a slow sphincter can cause this. So management options include medications. Those medications include medicines that help to relax the prostate and the sphincter. And so Flomax is a common one, maybe you've heard of. These others are also other options. The common side effects, though, are dizziness, fainting, low blood pressure, headache, nasal congestion. And so we have to be really careful in our Parkinson's patients with these medications. The thing, if you find that if we find that it is appropriate to potentially try this medication in our Parkinson's patients, we generally have you take it before bedtime to reduce dizziness. You can use a handheld or a bedside commode to avoid falls. And in patients with MSA or atypical Parkinson's, they may have worsening of their incontinence, so you really have to take caution. When medications aren't effective or aren't appropriate to use, then we have to talk more about catheters. So there's clean intermittent catheterization, which can be challenging for patients to do independently and requires caretaker assistance. There's suprapubic tubes. There's indwelling Foley catheters. And so this catheter that's up on the right-hand corner of the screen is an intermittent catheter that goes in and drains the bladder, and then it's removed. The one below it with the little balloon there goes in, and this little balloon helps to keep it inside of the bladder and keep it from falling out, and it can stay in for up to 4 weeks at a time. And so it goes in through the urethra. This is a female and a male urethra, and it sits in the bladder, and that balloon again keeps it from falling out. If it's just an intermittent catheter, it goes in through the urethra, drains the urine, and then you remove it. Suprapubic catheter works similarly, except for you bypass the urethra, you go into the lower part of the stomach and insert the catheter there, and it allows you to do the exact same thing. It drains the bladder, just avoids potential irritation from the catheter going through the urethra. Other causes of incomplete bladder emptying would be an enlarged prostate in men, bladder prolapse in women, or urethral strictures. And so management options for those include surgery to correct the obstruction. So in men, you can do a transurethral resection of prostate or a TURP. You want to avoid TURPs in people with MSA as it'll worsen the incontinence. Pessaries are little rings you put in the vagina that help to hold the bladder up. And then there's also pelvic organ prolapse repairs. You can also correct any urethral strictures with procedures if you have one. And in nocturia, again, which is waking up 1 or more times per night to urinate, you start with an evaluation, again, a bladder diary. We do a medication review, and we do a physical examination to evaluate for leg swelling. And conservative management options include leg elevation, lower leg compression, hose or stockings, fluid restriction in the evening if that is appropriate. You have to discuss with your neurologist. Pee before bedtime, avoid bladder irritants like caffeine, as we talked about before, using a bedside commode or a handheld urinal, and improving sleep quality and sleep hygiene by treating sleep apnea or any sleep disorders, using sleep aids or medications, quiet environment, dark room, and then trying to avoid caffeine in the evening. Again, medication, there are a few medications that are available. So overactive bladder medications, as I discussed before, like anticholinergics or beta-3 agonists. If a diuretic is appropriate, an afternoon diuretic can help to get rid of extra fluids before bedtime. And then DDAVP or desmopressin helps to reduce urine production overnight. And it has its own potential side effects, including headache, insomnia, and low sodium levels in the blood. And finally, I'll touch on urinary tract infections, which can be an issue in patients with neurologic conditions and bladder or neurogenic bladder. Some of the common risk factors for urinary tract infections with neurogenic bladder include incomplete bladder emptying. So the bladder isn't flushing out and the bacteria is allowed to sit in the stagnant urine, and it can reproduce and cause infections. Urinary catheters, they're a foreign body going into the bladder, so they can potentially contribute to urinary tract infections. Poorly controlled diabetes, kidney stones, urinary tract surgery, menopause, and female anatomy. So some UTI prevention strategies include hydration, hydration, hydration. Hydration is very good for the bladder. It's good to flush that urine out and flush out any bacteria that's there. Cranberry supplements and D-mannose powder are two supplements that have been well studied. The evidence for them are mixed. Some studies show that they work well and some show that they do not. I have some patients that have done well with them and some that have not. I think they're worth trying. By adding vitamin C to those two can help to acidify the urine as well and maybe help them to work a little bit better. Methanamine or Hiprex is a prescription medication and it's an antiseptic. It's like an antiseptic for the urine, and what it's supposed to do is keep the bacteria from reproducing in the urine to a level that's high enough to cause an infection. And there's daily low-dose antibiotics or prophylactic antibiotics. These are to help to prevent UTIs. And we have good evidence that they work, but they work for a limited amount of time. Eventually, the bacteria gets used to them and they become resistant. So you have to be very careful about using low-dose antibiotics. And then bladder irrigation is something that has been helpful for patients that have catheters, again, to help flush that bacteria out and hopefully help to prevent urinary tract infections. And finally, for women that are postmenopausal, there is level 1 evidence that shows that vaginal estrogen replacement can help to prevent UTIs by changing the pH in the vagina and helping to change the flora or the bacteria that live in the vagina. That's generally the source of the bacteria for infections. So next steps are to see your urologist or gastroenterologist and a gastroenterologist if needed to further discuss your management options. And just wanted to put a quick plug for our Stanford Pelvic Health Center, where we have multidisciplinary care from urology, GI, colorectal surgery, urogynecology, and pelvic floor physical therapy. Thank you.
All right. Well, thank you for all that great information. We'll move on to the 30 questions we received in advance of the webinar. Okay, so the first one we have here is the bladder not getting the message from the brain.
Yeah, so I tried to kind of show that in the animations there. Essentially, what's happening is that the part of the brain that helps to control the bladder is affected by Parkinson's and by atypical Parkinson's. So when we're little babies, our bladders fill halfway or full or not very much at all, and then they just contract when they want. And as we get older and our brains mature, then the brain kind of gets control of the bladder, and it's constantly sending a signal to the bladder not to contract, to relax until we give it permission to contract. And so what happens with Parkinson's and atypical Parkinson's is that the brain is no longer part of the equation, or if it is, its signal isn't strong enough to actually stop the bladder from contracting inappropriately.
Okay, the next one here is urinary incontinence an early sign of neurological illness, dementia, Parkinson's, or could it be something else?
That's a great question. So urinary incontinence can be caused by a number of things. So it's really important to just talk to your doctor and have an examination to try to determine what type of incontinence, because there's different types of incontinence. There's incontinence that you can get from being pregnant and having babies, and that's different. And then there's other types of incontinence that can be associated with Parkinson's and dementia.
Thank you for that. Yeah, that was a great question. As PD progresses, if you've already had urinary issues, will they continue to progress or might they level off?
That's a great question. Often the urinary symptoms will progress, but again, as we saw earlier, as I described earlier, there's different patterns. So what may happen is that you may develop a different pattern. So you started off with a lot of incontinence and frequency and urgency, and then you kind of progress to more the bladder not functioning well and not emptying your bladder well. So the answer is yes, it can progress, but it can just present differently.
Okay. Is there any effective treatment for the PSP patient who feels the need to urinate every 1.5 to 2 hours throughout the day and the night?
So it's worth trying the conservative therapies I described in the discussion in the talk. Um, Often I find that sometimes it's a little bit helpful, but often you're going to need medications and you're going to need further bladder testing to kind of determine the cause of the frequent urination so that you can target your therapy a little bit better.
Okay, thank you. My mother has LBD. She has no liquids at night and voids her bladder before bed, and yet at night she floods the bed with a very high quantity of liquid. How can this happen?
So this can be due to a couple of things. One of the things that we will often see is that the sphincter again isn't working properly. So it's not so much that she's drinking too much fluids, because as you mentioned, she's not drinking a lot. She's emptying her bladder before she goes to bed, but the bladder isn't capable of storing urine. Overnight, your kidneys produce urine. Your kidneys constantly produce urine. It's your kidneys. I like to use the analogy that your kidneys are like waterfalls. They're constantly dropping water into your bladder. So even if you've completely emptied it now, a few hours from now, it's normal to have some urine there. But our sphincters usually are the things that keep us dry. So what's happening to your mom is probably the sphincter isn't working properly, or her bladder is spastic, or she's sleeping so heavily that she's not able to sense that the bladder is full.
In LBD, is it common? Do people have trouble with like their kidneys being overactive, like perhaps at night? I mean, is that a problem that you've seen?
That's not, I mean, you can have overproduction of urine in general, and in those scenarios we'll do a bladder diary to try to determine that. But even if you make a lot of urine at night, if your sphincter works properly, you shouldn't wet the bed.
Okay.
You should wake up and.
Okay, thank you. What treatments are available for overnight incontinence? And I think you did cover some of that, but if you'd like to speak to that again. Or...
Yeah. So unfortunately, trying to treat the incontinence, determining what the cause is the sphincter or the bladder. If it's the sphincter, trying to address that. If it's the bladder, trying to calm it. Bed pads, and diapers overnight can be helpful. Yeah.
Okay. Why is my husband unable to tell that he needs to urinate during the day, but wakes up at night and needs to use the toilet?
So often patients with Parkinson's and atypical Parkinson's will have sleep disorders. So the waking up at night is more related to maybe sleep apnea or related to restless leg or insomnia. And then when you wake up, then you sense that your bladder's full and then you say, oh, I gotta go to the bathroom. So it's a combination of a bladder issue and a sleep disorder issue.
Okay. How can we as caregivers cope with night urgency and frequency?
So night urgency and frequency. So bedside commodes and urinals are often helpful, especially if the patient is, or your loved one is able to wake up and sense that they need to use the bathroom. Then if they have something right there by the bedside, then they can use that to empty their bladder.
Okay, now, so what are the symptoms of urinary tract infections in those with Parkinson's disease?
So the symptoms of UTIs should be similar to other people that do not have Parkinson's disease, mainly because the sensation should be the same. So it should be burning. The frequency and urgency part of it is probably the Parkinson's, but the frequency and urgency and incontinence may get worse, especially if your loved one is elderly. You can also see some confusion and some changes in mood and that type of thing.
Okay, so that kind of answers this next question. But my mother has CBD. When she has a UTI, her mental status changes. Why is that?
Yeah, and that's a very common thing in elderly patients. They just present differently when they're sick.
Hmm. Okay, so what's your opinion of prophylactic antibiotics to prevent UTIs? My mother has PSP and a catheter. The UTIs she's had are nearly deadly. And if you could explain again what prophylactic antibiotics are.
Right. So prophylactic antibiotics are a low dose of antibiotics that we generally use to treat urinary tract infections. And the thought is that if you have a low dose of this antibiotic, it'll prevent the bacteria from reproducing and causing an infection. And it's, again, it's effective. The problem is that it's generally effective for a limited period of time. Eventually, that bacteria there is going to become resistant to that antibiotic. And that's dangerous because if there are other infections that your loved one develops or other urinary tract infections, then we may not have many antibiotics available to treat that condition. And so I generally recommend having that discussion with an infectious disease doctor because they are great stewards of antibiotics and can help you to navigate that discussion.
And I think we've discussed, but you can touch on this again. What can be done to prevent recurring UTIs?
Yeah, so hydration is very important. Emptying the bladder as much as possible is very important. D-mannose powder, cranberry tablets with the 36 milligrams of the active ingredient has been shown in some studies to be effective. Again, in other studies, not effective, but worth trying. Pretty benign things to try. And then there's prophylactic antibiotics, as we just mentioned, and their role. And methamphetamine or Hiprax, which is, again, a prescription medication. It helps to keep the bacteria from reproducing to a high enough level to cause an infection.
Okay. My husband with MSA has had 6 UTIs this year, one of which went septic. He is colonized with pseudomonas. How do I keep him healthy? And could you explain the word septic and colonized?
So septic would mean that the bacteria from his bladder went into the blood system, and you can get pretty sick with that. Being colonized means that we give you antibiotics and it doesn't really clear the infection. Or we give you antibiotics and it clears it temporarily, and then the same bacteria comes back, but now it's just resistant to whatever antibiotic you were on. And so when we say colonized, that often means that just like our skin, we're all covered in bacteria from head to toe. So our skin is kind of colonized with bacteria. It doesn't cause an infection. We know the difference when we have an infection, you have a cut that's infected and it's painful versus when your skin is intact. So same thing with the bladder. You can get bacteria that now has developed a relationship with your bladder to where it's not causing an infection. It just kind of lives there. And that's what we call colonization. So how do you keep them healthy? Really, Pseudomonas is a tricky bacteria. That's one that I would discuss with an infectious disease doctor. And then if there's catheters or anything else involved, there may be other bladder irrigations and things that you can do to try to help keep that bacteria under control.
Okay. And then how do we know when urine does become colonized?
Generally, as I just said, it's when we check your urine and there really aren't urinary tract infection symptoms at that time. So there are some people that every time we check their urine, it has E. coli all of the time, and they don't have symptoms from that. We know that this is a strain of E. coli that for whatever reason has a symbiotic relationship with their bladder and is no longer, or maybe not symbiotic, but at least it's just hanging out there, but it's not causing inflammation in their bladder, not causing pain, not causing an infection.
So do you think patients should have periodic just urine tests? I mean, is that something you prescribe if they're healthy? I mean, if they're not having bladder infections at that time?
Yeah, we generally don't recommend that because there may be people that, even though have Parkinson's, who have bacteria in their urine all the time. And what happens is, oh, we're just routinely screening it, and you're getting antibiotics unnecessarily. And then
Okay.
you develop significant and dangerous resistance to antibiotics. So that's why urine tests should only be taken when a patient is having symptoms of a urinary tract infection.
Okay, thank you. My husband has Parkinson's and a catheter. Recently, bladder stones have blocked the catheter, causing overflows. What can we do?
So the stones need to be treated. So your husband should see a urologist to see if those stones can be removed. Sometimes they're pretty small and they can be just flushed out of the bladder. Sometimes we have to go into the operating room and break up the stones and remove them. And then ways to prevent them moving forward again is irrigation. So these stones form because of stagnant urine inside of the bladder. So flushing the bladder, irrigating the bladder periodically, and have that discussion with your urologist to try to determine how frequently you need to do it. Some of my patients, I have them flushing their bladders daily, and it's been effective for them.
And that's something they can do at home then, something they can do with self-care. Okay, that's good to know.
Exactly.
Okay. My father has a Foley indwelling catheter, but there's still urine leaking out. We were told this is due to bladder spasms. What are those and how can they be treated?
Exactly. So bladder spasms are those involuntary contractions that I showed you on that little tracing before. So what's happening is the bladder is just inappropriately contracting, and it's contracting forcefully enough that's able to push the urine out around the catheter. And so the bladder spasms can be caused by the catheter itself. So your bladder isn't happy with the catheter in there, or it thinks that the catheter is urine or something that shouldn't be there and it's trying to push it out. Or it can be caused by his neurologic condition and his bladder is just spastic. So how you can treat those, there's a number of ways you can there are oral medications that you can take to try to calm the bladder, like the anticholinergics that we talked about before, or myrbetriq, or there's Botox that can be injected into the wall of the bladder to help calm it, to get rid of those spasms.
And why does a catheter continually cause UTIs?
So this is a tricky question. So catheters have, and anytime you're placing a catheter, there's potentially some bacteria that's going into the bladder. And so when you have a catheter, you're at increased risk of a urinary tract infection compared to someone who doesn't have a catheter. But if you're not emptying your bladder well either, without a catheter, you're still at increased risk of having a urinary tract infection. So they have very important roles. They're also important in making sure that the urine isn't backing up to the kidneys and causing other issues. So this question goes back to that discussion about colonization. Patients who have catheters are more likely to be colonized. They're more likely to have this bacteria that's their own body's normal bacteria that gets introduced into the bladder, and it's not necessarily causing an infection, but there's bacteria there every time you check it.
Okay. Any issues with prolonged external catheter use?
It's just like anything else that any other external device that you wear. If you don't want to leave it on for too long of a period continuously, just because it can cause bruising and it can cause breakdown of the skin. So as long as you're giving the skin enough time to recover in between uses, it's fine to use. And the other thing is to just make sure that the external catheter has been properly sized and that it's not too tight.
Okay, and can these urinary symptoms we've been talking about be intermittent?
They can come and go but for the most part, once they're there, they're there.
How do medications for urinary issues affect blood pressure? That's a huge issue in MSA.
Yes.
Yeah.
So when we're talking about medicines that help you to empty your bladder better, that help relax the sphincter and help relax the prostate, those medicines can lower your can lower your blood pressure. And so I actually rarely use those in my patients that have Parkinson's or atypical Parkinson's. And then the other medicines and then also in MSA as well, that those medicines can make your incontinence worse, actually. Other medicines like myrbetriq have an effect on the blood pressure, but it's the opposite effect. It can cause potentially a rise in the blood pressure. So if there's a low blood pressure issue, it may potentially be beneficial.
Okay. Is frequently urinating to the point of losing electrolytes an issue in MSA? And can you explain electrolytes briefly?
Yeah, so electrolytes are things in your blood that help to keep things balanced. So we're talking about sodium, we're talking about potassium, chloride, things like that. And so urinating frequently is generally not due to overproduction of urine. It can be. If it is, then that's kind of a separate problem. It's usually due to inability to store urine in your bladder. So overproduction of urine is when your kidneys are just taking every bit of water that you're drinking and just pumping it right out. That's pretty rare. That's generally not what's happening in these scenarios. But if your kidneys are just pumping urine out, producing urine, pumping urine into your bladder, constantly, then yes, that can affect electrolytes, and that's a condition that needs to be evaluated by a nephrologist, a kidney doctor.
Okay. I have to get up once only in the middle of the night to urinate. I'm concerned about falling and have trouble getting back to sleep. Would I be a candidate for something like demosuppression?
Yes, if the concern is more so that you're concerned about falling, I would recommend using a bedside urinal or a bedside commode. Desmopressin can be effective for people who pee frequently at night. So one time at night, you probably don't need desmopressin. If it was a benign medication, I would say doesn't hurt to try it, but there are potential side effects with it. And in your case, it doesn't sound like it's worth the risks of those side effects. And then desmopressin works in people who overproduce urine at night. So again, you would need a bladder diary, a 3-day bladder diary that's recording your fluid intake and your urine output to try to determine if there's overproduction at night, and there's ways of calculating that.
Okay, thank you. Can you address bladder retraining to hold more before having to go?
Yeah, so bladder retraining is where you get the urge to urinate and you try to distract yourself or try to ignore it, try to teach your bladder to hold urine longer. With that said, it doesn't work well in Parkinson's or people with neurologic condition because it's not a mind over matter type issue. It's literally your brain is not being included in the decision to contract. So what would happen in a Parkinson's or atypical Parkinson's person who tries to just wait to go to the bathroom is that they're going to have an accident, they're going to leak.
Okay. What exercises are helpful, if any, for treating PD-related urinary incontinence?
There's pelvic floor physical therapy in general for people who have urinary incontinence. I find that it's not helpful in Parkinson's because, again, you have this issue of a sphincter that's not working properly to begin with. So strengthening it is probably going to be difficult because neurologically you don't have great control of your sphincter to begin with. Secondly, strengthening it could potentially make it harder to pee because part of your issue is that it doesn't relax quickly enough and maybe doesn't relax enough to begin with. So I find that pelvic floor physical therapy is not something that I recommend for my Parkinson's patients.
Okay. Can bladder training work if there is dementia?
No, because the patient really needs, or your loved one really needs to be aware of everything that's going on and the goals and what we're trying to achieve. And so that's really tough to do.
Okay. Can mindfulness or meditation help with anxiety about incontinence?
It can help with anxiety about incontinence, but it's not going to help the incontinence.
Okay. And then what is the future for incontinence without drugs?
So there are some of the advanced therapies that I discussed. There's other devices that are coming out, like the InterStim, that in the next year or so we'll have some that are safe and compatible with MRI. There's with the percutaneous tibial nerve stimulation, where we um, place the little acupuncture needle in the ankle. There's devices that are going to be coming out in the next year or two that just go underneath the skin, so you can do these therapies at home on your own without having to come into the doctor's office to have them done. So, and there are other things that are in the pipeline that are a little further out.
Okay, thank you. How do you distinguish neurological causes versus BPH, benign prostatic hyperplasia in men?
So generally with that initial evaluation, so when you come into my office, I ask you a bunch of questions. I do an examination. I check the size of your prostate. I will generally ask you to do a Euroflow test so that I can check the flow and see if it's abnormal. I'll do a bladder scan to check to see if your bladder is getting empty. And if any of those things are abnormal, then I recommend a bladder function test, and that generally will help answer that question.
Okay. How do Parkinson's disease and chronic kidney disease affect each other?
I don't know of any correlation directly between the two. Um, in Parkinson's disease, if you aren't emptying your bladder well and you're retaining a lot of urine, you could make your chronic kidney disease worse for sure in that way. But I don't know of any other connection between the two conditions.
Do urinary problems present and progress differently depending on PD versus MSA or other atypical Parkinsonism disorders?
Yes. With MSA and a lot of the other atypical Parkinsonism disorders, the urinary problems typically progress a lot more quickly, and they're often more severe.
How do I find a urologist experienced in neurological issues?
Well, I would start by talking to your neurologist. So your neurologist hopefully knows someone that they typically work with in the community that has an interest or has some additional training in neurologic bladder issues. Just about every academic medical center is also going to have someone who is fellowship trained in treating neurogenic bladder.
And how do I speak to my neurologist about my urinary issues?
Well, the first important thing is to let them know that you're having them, because a lot of the time there's so many other symptoms that are associated with Parkinson's and atypical Parkinson's, and that takes a lot of the time of the visit. Just let them know that you're having those issues, and a lot of the time then they'll try some of the things that we just talked about today, and if it's not getting any better, then they'll get you referred over to a urologist who can evaluate you further and offer other therapies.
Okay, so we have a couple more questions here that people have sent in just now. What causes urine to have a bad odor? We suspect it is due to dehydration, or maybe the patient isn't fully emptying even with a catheter.
Often dehydration and diet are cause of malodorous urine. In some cases, it's an infection.
Mm-hmm.
But most of the time, especially if there's a catheter in place, it may also be that there's a lot of buildup in the bladder, and that, again, the bladder needs to be flushed out because there's just buildup of gunk in there. And so just like your skin, anywhere else, the inner lining of your bladder, those cells slough off and they need to be flushed out. And when you have a catheter, it's a little bit harder for them to flush out. So you sometimes have to manually flush it out.
Okay. I have MSA. My bladder spasms are painful. I self-cath 4 times a day. Can I do anything else for this pain?
Yeah, so treatments for the bladder spasms involve oral medicines to help calm the bladder. If that isn't effective, Botox is very effective at treating bladder spasms.
Okay. Have you heard of taking Elavil for calming the bladder?
Yes, you can take Elavil for that. It has some of that anticholinergic effect that those medicines that we talked about before, but it's not the best medicine for that. It's if you're going to take an anticholinergic, you should take one that focuses more on the receptors in the bladder.
Okay. My husband has LBD. After he urinates and leaves the bathroom, he often wets the front of his trousers. The internist says this is common in older men. Is it common, or is it a sign of something else like poor retention?
Yeah. So often that's called post-void dribbling. So that just means that there's some urine that exited the bladder and it was just very slow to completely drain from the urethra before your husband left the bathroom. So the most important thing is to stand there for another minute and just kind of give it a chance to drain. Again, everything's a little slow. Secondly, you can kind of shake things off. As I tell my patients, shake things off, try to shake out any additional urine that may still be trapped in the urethra. And then using a little piece of tissue and just dabbing the urethra before you leave the bathroom to help try to catch any additional drops of urine that are there.
Wow, well, great. Well, thank you so much for all this fabulous information. I'm sure it's really helped a lot of people here today. So for further information on urinary issues, we have the slide up here that you can reference, and this will be on BSN's website as well, so brainsupportnetwork.org. You can check that for copies of these slides as well. And also, and here's our Brain Support Network information here. And please, once again, we do ask that you complete our survey. We do need your help in improving these webinars in the future. So we want to thank everybody so much for their participation today. And we hope that everyone has a great afternoon and a good weekend. Thanks again.